Good morning, everyone, and welcome to our May Commission meeting. It's been a couple of months since we've seen all of you, but it's lovely to be here this morning. I know the Commission has been busy with open enrollment. The agenda today is very exciting, so I'm looking forward to digging in. Matt, why don't you take us through the agenda and we'll get this meeting going.
Great. Thank you, Madam Chair. Welcome, commissioners. It is great to see you after a short commission layoff. As our chair said, we've been very busy at the GIC with the annual enrollment, with the reduction in the waiting period project, which is very exciting. It's a busy time in the legislature on healthcare matters, so we've got a lot on our plate, but happy to walk through a number of really important updates for you today. So first off, we will have Lauren Makashima, who's our data analytics manager, to present the out-of-pocket report for this year, highlighting trends in our member cost sharing, but with some new insights this year based on some really thoughtful analysis. I want to thank Lauren and Margaret and Jim for guiding this work. Every year when we do it, we were able to glean some new insights here. So really excited to bring that to you today. Next up will be an update on the reduction in the waiting period project that I mentioned. Deputy Executive Director Erica Shabelli will provide an update there. A significant portion of the work here has been change enablement, which requires us to work with colleagues across state government. We're doing so with a great deal of support from our colleagues, so Erica can update us there. We'll also have our General Counsel, Andrew Stern, presenting on proposed amendments to our regulations that are necessary to implement the reduction in the waiting period. This has been a major project for us this year, and we're really excited that we're getting close to executing this change. Next, we'll have next up will be our CFO, Jim Rust, who will present two items: the FY25 trust fund request, which will be a vote, and we'll close out with Jim presenting his CFO report. So today, as you can tell, mercifully, you'll hear a little less from me and more from the tremendously talented and hardworking team we have here at the GIC. With that, Madam Chair, happy to turn it back over to you for the minutes.
Yes, thank you. And speaking of talented teams, I would like to introduce who's on our commissioner board and here today, which I didn't do when I opened the meeting. So I want everyone to know that we are joined here by Bobby Kaplan, who's our vice chair. I'd like to welcome Dana Sullivan, who is the designee for ANF today. So welcome, Dana. We have designee Rebecca Butler for the Division of Insurance. We have Liz Shabbat. We have Toby Choate. We have Tamara Davis. We have Jane Edmonds. We have Joe Gentili. We have Jerzino Garand. We have Patty Jennings, we have Eileen McEnany, we have Melissa Murphy Rodriguez, who may have joined by now, and if not, she is in process of joining. We have Jason Silva, Anna Sinenko, and Timothy Sullivan. So that is our commission team today, and I'm thrilled and can't wait to see you all again in person sometime, but nice to see you on camera. So at this point, I will entertain a motion to review the minutes and approve them from our February 29th meeting. Do I have a motion?
So moved.
Bobby, seconded by Liz. All right, so at this point, I will turn it over to Andrew, our general counsel, to hear a aye, nay, or abstain. So, Andrew, I'm an aye.
Thank you, Madam Chair. Vice Chair Kaplan.
Aye.
Designee Sullivan.
Aye.
Designee Butler,
Aye.
Commissioner Shabbat,
Aye.
Commissioner Choate,
Aye.
Commissioner Davis,
Aye.
Commissioner Edmonds,
Aye.
Commissioner Gentile,
Yes.
Commissioner Guerin,
Here.
Commissioner Jennings,
Abstain. I was not present.
Commissioner McEnany, come back, Commissioner Murphy Rodriguez,
Aye.
Commissioner Silva,
Aye.
Commissioner Sinenko,
Aye.
Commissioner Tim Sullivan,
Aye.
Commissioner McEnany, are you on? She must be having technical problems. The vote passes regardless, and if she can get on, she can tell us what she voted.
Okay, that sounds good, Andrew. Thank you. So at this point, our minutes are approved. I am going to turn this back over to Matt to take us through the next agenda item.
Thank you, Madam Chair. Just like to highlight a few items from the written Executive Director's Report sent out to commissioners with the packet. On the HR front, we're happy to welcome 2 new employees to the GIC. You may have already noticed the name Karen Jenkins in your inbox. She is our new executive assistant at the GIC. She joined us in February and will be executive assistant, but really more office manager and support for the entire executive team. So you'll be hearing from her on occasion around commission meetings and scheduling needs. So welcome, Karen. We are also looking forward to welcoming Eric Aravalo to the operations department. He will be joining in the data entry and systems unit next week. It's a very busy time of year in that unit as we do all of the back-end work following annual enrollment and prepare for coverage on July 1. So we're pleased to have him join the team. So hope you'll join me in welcoming both Eric and Karen. On the legislative side, legislature is in the home stretch of their 2-year legislative session. So as always, the action is really starting to pick up there. We are monitoring the creation of the state budget, which the House passed in April and which will be before the Senate next week for a vote. There is also, as you may have heard, a substantial health care bill on the House floor, actually today for votes. So we will expect to have more to report to you on both of those items as those bills get closer to the finish line. Lastly, we're pleased to report on the annual enrollment front that we successfully onboarded the latest municipal entity to join the GIC. This is Shore Collaborative based in Chelsea. So big thanks to our team who worked closely with staff at the collaborative. This can be a complex transition for a municipal entity, but I'm happy to say that we got very glowing feedback from the collaborative about how helpful and just friendly our staff was in guiding them through that process. So a lot of work there, but it went all quite smoothly. And with that, I am happy to take any questions on the executive director's report.
Yeah, I don't see any hands up. Is there any color you can add to the healthcare bill that's being debated for those of us who may not have all the details on it?
Yeah, happy to. So I say this knowing that there are 49 amendments, give or take 48, 49 amendments, so it may well change today. But there are a number of different categories of policy in the bill. There's with the steward healthcare crisis, and really can't call it anything other than that. There's a good deal of policy change in there to attempt to prevent that sort of thing from happening again, particularly as it relates to the private equity dimension of Steward Healthcare. There are a series of changes to the Health Policy Commission, the composition of the commission. I think really importantly, how they calculate and implement the healthcare cost growth benchmark. This is the first time that they've really, since the passage of Chapter 224 in 2012, the first time that they've really made substantial changes there. There are also a series of changes around health planning, trying to it would move the sort of health system planning function from the Department of Public Health to the Health Policy Commission, in addition to understanding where healthcare needs are and the capabilities of the system to meet those needs. The intent is also to have more insight into the closure of healthcare facilities and how that impacts the capabilities of the healthcare system. Again, highlighted most recently with the Steward Healthcare crisis. There aren't any real substantive changes that relate directly to the GIC, but of course, the changes to the healthcare cost growth benchmark are important for us because we have used that structure as an important part of our strategy and accountability of our carriers to cost growth. They have performance guarantees that are linked to their trend as it relates to the benchmark. So we are following it closely. I'd say those are the highlights. I'm probably leaving some out, but those are the ones top of mind for me.
All right, thank you. I see we have two hands up, Eileen and then Bobby. So Eileen, hi there. Why not you go? Go ahead.
Good morning. Sorry, I am late to the meeting, just on the MBTA, and you can never predict. But I wanted to underscore a couple of points that Matt made. And certainly upon review of the healthcare bill, from my perspective, I am concerned about the changes that they're making to the Health Policy Commission because they remove the dedicated seat for purchasers. And there are a lot of healthcare stakeholders that now will be on the Health Policy Commission. And I think it just makes it more difficult to look objectively at the cost benchmark. There's also an advisory committee that's established that, again, is made up of a lot of the healthcare stakeholders, and they have the ability to recommend a point higher or lower on the benchmark. But given the composition of that advisory committee, concerned that it will add to the annual cost benchmark. The only other thing I would say is, again, from an affordability and a cost perspective, the healthcare bill is proposed, at least out of Ways and Means, has a floor on the rate reimbursement for providers, but no corresponding ceiling. So just concerned that that means there'll be greater inflation and that the price, which makes up really the premium, it's utilization and price, unit price, that will increase across the board over time. So paying close attention and concerned about that as well.
Yeah, thank you for flagging the rate provisions and the concern about those. That has been, as you know, Eileen, a moving target with a redraft of the bill that came out this week. So we and others are digesting what that all means for us, but we're also tracking that closely.
Yeah, I mean, I do hear the concern and would love to see if there's possibility to get a ceiling rate in there to correspond with the floor. So that's good to note there, Eileen, and thank you. Bobby, I see you have your hand up. Go ahead with your question.
Yes, I actually have two questions. One is, I'm curious as to the number of subscribers in the Shore Collaborative, how many there are. And I also wanted to ask about our budget request. And if you anticipate, sort of your budget request being approved.
Why don't we take the second question first, and I'll hand that over to Jim Rust, our CFO.
Thank you.
Morning. Yes. So we've been working with House Ways and Means, Senate Ways and Means, and of course A&F prior to that on our budget submission, and it's been well received and supported. I can tell you all along the way. So we don't have any concerns about the budget request not being fulfilled for FY25 at this point. Obviously, there's a little ways to go, but all signs are good. So we're in pretty good shape there.
Great. Thank you.
And I think I'll ask Paul Murphy to speak about the Shore Collaborative. My sense is that we're about 140 members that have come on, but I don't want to misspeak. Paul?
No, that's correct, Matt. 140.
And that is inclusive of the 25 retirees, or is that in addition to the 25 retirees?
It includes the 25 retirees.
All right, and now I
Thanks,
see
Paul.
Toby
Thank you.
has his hand up. Hey, Toby, how are you?
Good morning. Jim, what was the percentage increase you asked for of the budget year over year?
It is. I have it right in front of me, actually. So it's a little bit, as these things tend to get, a little bit of a moving target, but basically it comes up to about 8.5, 8.7 all.
I'm sorry, you broke.
8.5, about 8.5 to 8.7, depending how you do some accounting around how our subsidies are used, but in that ballpark.
And they're happy with that?
We've got, yes. I mean, I would say bottom line is yes, but we have more pressures coming into this year than in some other years with some of the pharmacy things like the GLP-1 costs and those kind of things are moving targets. But there's also some offsetting items going the other way. So we feel pretty good about it. But as you'll see in my budget report, both this year and probably next year will be a little bit tighter years than we've had in the past. That would be my forecast. But we feel pretty good about it. This is a good, accurate estimate of what it'll cost to provide the benefits next year.
Thank you.
You're welcome.
I don't see any other questions. Good dialogue. We can keep moving. Go ahead and get started.
Yep. So we'll do a brief review of the calendar. So next month we will be back to give you a report in more detail, as we always do, on how annual enrollment went this year. As I referenced earlier, the back end work is substantial and will continue for a couple more weeks, which is why we do this in June. I can report that the annual enrollment went well and smoothly this year. Very, very busy time, as it always is for our operations unit. I will say, just as a little teaser, we had about 4,300 members switch plans, which is a pretty typical year for us. And the use of the My GIC Link member portal continues to increase. The vast majority of those who made those changes this year did use the portal. So much more to come on this in June from both Paul Murphy, our operations director, and Stephanie Sutliff on the IT side. We also look forward to having Lauren Peters at our next meeting, Executive Director of the Center for Health Information and Analysis. She will present findings on a report, their 2024 annual report, with a particular focus on prescription drugs, which of course continues to be a substantial cost challenge to us. Finally, the vendor management team is preparing to bring a recommendation to you for a consultant to assist with the reprocurement of our dental benefit. which is next up on our procurement cycle. And then after our summer break, we'll be back to you in the fall. But as you will see in June, we will have more detail about how our fall meetings will agendas will fill out. I do want to note that we anticipate having at least one in-person meeting in the fall, so more to come on that, and it'll be great to see everyone. Any questions on the calendar?
I don't see any. I think we're good. We can keep moving.
All right, terrific. So with that, we'll move on to our first main agenda item here today, and we'll hand it over to Lauren Makishima, our tremendously talented data analytics manager, to present the out-of-pocket report.
Thank you, Matt. Good morning, commissioners. My name is Lauren Makishima. I'm the data analytics manager here at the GIC, and it's great to be back this year to present the out-of-pocket report for fiscal year 2023. As a reminder, fiscal year 2023 ran from July 2022 through June 2023, which was prior to the most recent medical and prescription drug procurements. And feel free to raise your hand in Zoom if you have any questions as we go along. Next slide, please. All right, so we have 3 goals for today's report. Our first goal is to explore trends in GIC member out-of-pocket costs. Then we will take a look at how GIC member out-of-pocket costs compare to state and industry benchmarks. And finally, we'll discuss some reasons why some GIC members might incur high out-of-pocket costs. Next slide. All right, and before we dive into the report, we'll do a quick refresher on what out-of-pocket costs are and how our plans are structured with regards to those costs. Out-of-pocket costs are the portion of costs for medical and pharmacy services that are paid by the member and may include deductibles, copays, and coinsurance. Once a member's medical and pharmacy costs combined reach the out-of-pocket max, the GIC covers 100% of the cost of that member's covered services. All non-Medicare GIC plans have a $5,000 in-network out-of-pocket max for individual policies and a $10,000 in-network out-of-pocket max for family policies. For a family policy, no single member's in-network out-of-pocket costs will exceed $5,000. It's important to note that plans that have out-of-network benefits have a separate $5,000 individual or $10,000 family out-of-pocket max that only applies to out-of-network services. Next slide, please. All right, so starting off with our first objective, we're going to take a look at trends in GIC member out-of-pocket costs. Again, remember that fiscal 23 was the 5th and final year of the previous set of medical and pharmacy benefit contracts. So this is a great opportunity for us to look over the course of those 5 plan years to understand what really happened with out-of-pocket costs during that time. And of course, this 5-year window was also notable because of the COVID-19 pandemic. We'll discuss the impacts of COVID on out-of-pocket costs in later slides. Next slide. All right, so jumping right into the data, this graph shows aggregate out-of-pocket costs from fiscal 19 to fiscal 23 for non-Medicare members in the top set of bars and Medicare members in the bottom set of bars. The medical portion of out-of-pocket costs is in purple and the prescription drug portion is in yellow. Before we dive into the numbers, you'll notice that fiscal 19 and 20 are missing for Medicare. This is due to an improvement that we made in the data warehouse last year to process Medicare prescription drug claims more accurately. Previously, prescription drug out-of-pocket costs were overstated for Medicare members, but this improvement in processing could only be applied to claims paid in calendar year 2020 and later. So fiscal 19 and 20 are excluded from this graph. Returning to the findings, so between fiscal 22 and 23, total out-of-pocket costs increased 3.9% for non-Medicare members to a total of $219 million in fiscal 23. And total Medicare out-of-pocket costs increased 4.5% to $72 million in fiscal 23. However, when we look across the whole 5-year period, it's important to note that membership shifted during this time. Non-Medicare membership decreased 6.4% over this period, while Medicare membership increased 7.5%. So rather than looking at total dollars, looking at out-of-pocket costs on a per member per month basis will better reflect the trends and the changes in member out-of-pocket spending. Next slide, please. So here we're looking at out-of-pocket costs per member per month for Medicare members, with prescription drug spending again in yellow and medical out-of-pocket spending in purple. So starting with the medical, we can see that out-of-pocket costs remained fairly stable over the 5-year period, starting at $14.22 per member per month in fiscal 19 and ending at $14.23 per member per month in fiscal 23. Looking at the prescription drug slide in yellow, we can see that out-of-pocket costs increased $2.74 per member per month between fiscal 21 and 23, ending up at $38.46 per member per month. Next slide, please. All right, now we'll take a look at the non-Medicare population. So again, we have medical out-of-pocket PMPMs in purple and prescription drug out-of-pocket PMPMs in yellow. I'm going to start with the medical and come back to prescription drugs in a few slides. So the first thing you'll notice is the dip in out-of-pocket spending between fiscal years 19 and 20 from $42.70 to $36.89 per member per month. And this was due to decreased utilization at the start of the COVID-19 pandemic, as appointments for non-urgent care were largely delayed or canceled. Starting in March 2020, the GIC waived all cost sharing for telehealth services and all COVID-19 testing and treatment. And this policy continued through June 2021, so through the end of fiscal year 2021. So what we see in the data is that even as utilization began to rebound in fiscal 21, out-of-pocket costs remained low, with out-of-pocket PMPMs increasing just 3 cents between fiscal 20 and 21. And this was due to the waived copay policy. After that policy was sunset, we see out-of-pocket costs return to slightly above pre-pandemic levels at $43.22 PMPM in fiscal 22. And in fiscal 23, we see another increase to $45.68 per member per month. Across the 5-year period, medical out-of-pocket costs increased $2.98 per member per month, which was a total increase of 7%. If we were to smooth out the effects of COVID-19 and assume that PMPMs had increased at a consistent rate over the 5 years, that would be the equivalent of a 1.7% year-over-year increase. On the next slide, we'll take a look at these medical out-of-pocket PMPMs, and we'll break them down into copays, coinsurance, and deductibles. Next slide, please. So the totals on this slide match up to the purple line on the previous slide, but here we've broken those costs down into copays in purple, coinsurance in yellow, and deductibles in green, all on a PMPM basis. So here we can really see the effect of the waived copay policy, with copay PMPMs decreasing from $20.83 in fiscal 19 to $16.57 in fiscal 20. With a further decrease to $15.24 in fiscal 21. If we compare the first and the last bars on this graph, we can see that copay costs on a PMPM basis are actually the same in fiscal year 2023 as they were in fiscal year 2019 at $20.83 per member per month. And this makes sense given that GIC plans have a largely copay-based benefit design, and there were no major changes to benefit design during this period. But what that means is that all of the $2.98 PMPM increase that we observed on the last slide occurred in coinsurance and deductible costs. Remember that coinsurance amounts are set at a percentage of the allowed amount, and until a member meets their deductible, the deductible costs equal the full allowed amount for that service. So that means that coinsurance and deductibles are areas where members will feel the impact of rising provider prices, as opposed to copays, which remained at a set amount during this time, regardless of changes to allowed amounts. Next slide, please. All right. So here we're looking at the same copay, coinsurance, and deductible PMPM bars. So that's the purple, yellow, and green at the bottom. But we've added in the blue line here, which represents GIC paid per member per month. Starting from the left side of the graph, we can see how GIC paid PMPMs decreased 3.7% in fiscal 20 as utilization decreased due to COVID. But unlike the out-of-pocket PMPMs, GIC paid PMPMs increased in fiscal 21 as utilization rebounded and as GIC absorbed the costs of the waived copays. GIC paid PMPM continued to increase over the next 2 fiscal years, ending fiscal 23 at 27% above fiscal 19 paid PMPMs. During this time, GIC paid dollars increased from $435 per member per month to $552 per member per month. Again, during this time period, out-of-pocket costs increased 7% from $43 to $46 per member per month due to the GIC's copay-based benefit designs. So to sum up the story that this graph is telling, over the 5-year period, medical inflation was essentially absorbed by the GIC, and members were shielded from increasing out-of-pocket costs. Of course, that doesn't mean that members weren't impacted by medical inflation at all, because the GIC needed to raise premiums to cover those rising claims costs. This does align with GIC member preferences expressed in the member survey that we fielded in 2021, where members said that they would prefer to pay higher premiums in exchange for lower out-of-pocket costs. As HPC has done an excellent job of reporting on, provider prices continue to be the primary driver of medical spending growth, and GIC plans are, of course, subject to those same market dynamics. As we'll see in a few slides, many employers have shifted some of the rising costs to members in the form of higher deductibles, copays, or coinsurance. And while the GIC has protected members from increases in out-of-pocket costs thus far, the most impactful affordability strategies would ultimately need to address high and rising provider prices. Before we move on from this slide, I also wanted to note one exception to that price-driven trend, which is behavioral health. For behavioral health professional services, both prices and utilization have increased substantially during this 5-year period. We view this as a largely positive development because that means that patients are now accessing the services that they need, and behavioral health providers that have historically been undercompensated are now receiving higher reimbursement rates. Next slide, please. All right. So now we're going to return to that out-of-pocket PMPM slide for non-Medicare members, and we're going to focus on the yellow line, which represents prescription drug out-of-pocket costs. So we can see that growth was relatively slow in fiscal years 20 and 21, with 1.9% and 1.4% year-over-year increases. That growth accelerated between fiscal 22 and 23, increasing 6.2% or 91 cents per member per month from $14.66 PMPM to $15.57 PMPM. Next slide, please. One of the major factors in that acceleration of prescription drug out-of-pocket growth was increasing utilization of GLP-1 agonist drugs for diabetes and weight loss treatment. In each of these graphs, the green line shows GLP-1 drugs for diabetes indications, and the purple shows GLP-1 drugs for weight loss indications. Overall, 35 cents out of the 91 cent PMPM increase that we saw in the last slide can be attributed to increasing uptake of GLP-1 drugs. The graph on the left-hand side shows the increase in out-of-pocket PMPMs, with GLP-1 diabetes drugs increasing 15 cents PMPM and weight loss drugs increasing 20 cents PMPM. The middle graph shows the increase in the number of scripts for each drug type. Scripts for GLP-1 drugs with weight loss indications increased 219% as new drugs came on the market and as patients and prescribers became increasingly aware of these drugs. During this time, GIC paid amounts increased $3.90 per member per month for GLP-1s for diabetes, and $5.89 per member per month for GLP-1s for weight loss. As you've heard in prior presentations, these drugs are very effective but very expensive. So we do have a prior authorization process in place to ensure that patients are only taking these drugs when medically necessary. Next slide, please. All right, moving on to our second objective. So now that we've taken a look at the trends in GIC member out-of-pocket spending, let's put those figures into the context of the broader market. Next slide. This slide shows the percent of medical and prescription drug claims cost paid by the GIC for fiscal 19 through fiscal 23. This is just a different way of showing the trend that we talked about on the previous slides, which is that as medical and prescription drug costs have risen and out-of-pocket costs have only increased slightly, the GIC has covered an increasing portion of costs. Over these 5 years, that portion has risen from 90.7% of costs in fiscal 19 to 92.6% of costs in fiscal 23. Next slide. This is a slide from CHIA's most recent annual report covering data through calendar year 2022. Each bar represents a different market sector, and the length of the blue bars or orange bar reflects the percent of claims costs covered by fully insured medical plans in Massachusetts. The most relevant comparison for the GIC would be the jumbo group plans with 500 or more employees, which is the bottom blue bar in this graph. CHIA reports that these plans covered 89.7% of costs on average in 2022, with an average of 87.2% across all market sectors. From the previous slide, we know that GIC covered over 92% of costs during this period.
92 versus 89.
And I see we have a question.
Thank you. I'm just trying to figure out, when you do the comparison, how you account for the difference in benefit package, right, in levels, because plans have different benefit tiers. So could you just explain that? So the amount that they cover, it may not be an apples to apples comparison, or could you just explain how you determine that?
Yep. So this is a pretty broad comparison, I'd say. We do our best to find the most applicable comparisons for each metric, but as you rightly point out, there are absolutely differences in benefit design and in premiums as well. So this is just one way to get a comparison, and we'll look at a couple other ways of comparing GIC member out-of-pocket costs in the next few slides. All right.
I don't see a follow-up question, so you can keep going, Lauren. Thank you.
Okay, sure. One more note on this slide. I just wanted to note that CHIA also reported that benefit levels decreased across all market sectors between calendar year 2020 and calendar year 2022. And that may indicate that plans are shifting some of those rising costs to members through out-of-pocket costs, or it may indicate that members are choosing to enroll in plans with higher cost sharing in exchange for more affordable premiums. During that same period, as we saw in the previous slide, GIC benefit levels increased. And again, that was due to the largely copay-based benefit design that shielded members from out-of-pocket increases. Next slide, please. All right, this graphic is from the Willis Towers Watson 2023 Financial Benchmark Survey. And this shows how GIC benefits compare to other large plans nationally and within the industry. So GIC members pay 8% of total costs out of pocket. So that's the pink slice in the pie chart on the bottom right, which is below the overall database average of 15% of total costs. That's the pink slice on the bottom left, and below the industry average of 11% of total costs, which is the pink slice in the middle pie chart. The bar charts above show those same figures in dollars, although it's important to note that the dollars for these benchmarks are unadjusted for factors where they may differ from the GIC, like age, gender, family size, and geography. Next slide, please. All right, so this is another slide from CHIA's annual report, and this graph shows member cost sharing by market sector for all fully and self-insured plans cited in Massachusetts. While the methodology for CHIA's reporting differs from the figures that we pull from our claims data warehouse, it does offer a helpful comparison between GIC cost sharing at $48 per member per month and the jumbo group cost sharing at $54 PMPM. Between calendar years 2020 and calendar year 2022, GIC plans consistently had the lowest cost sharing PMPMs among all employer-sponsored plans. Next slide, please. All right. So far we've taken a look at trends in the whole GIC population, as well as how those trends compare to the rest of the market. Finally, we'll take a look at some of the reasons why some GIC members might incur high out-of-pocket costs, despite GIC's relatively low average out-of-pocket costs compared to the rest of the market. Next slide, please. So this slide shows a distribution of households by their fiscal 22 plan year out-of-pocket costs. So the height of the purple bars shows the number of households, and that vertical axis is to the left-hand side. And the position on the horizontal axis indicates the bracket of out-of-pocket spending that that household fell into. The yellow line, which has the vertical axis on the right-hand side, represents the cumulative percent of total households in each bracket, or in other words, the percent of households that fall above or below that particular spending bracket. In fiscal 22, the median out-of-pocket household cost was $907. See, we have a question?
Hi, thank you, Lauren. Thanks for all of this data. I just had a clarification question. Is this
Sure.
total out-of-pocket cost by household, including both in-network and out-of-network?
Yes. So this is for all covered services and includes Medicare and non-Medicare. And finally, we do include prescription drug penalties, which we'll be talking about in a little bit more detail as part of the definition of out-of-pocket costs for this slide. All right. Next slide, please. Okay, so in fiscal 23, the median out-of-pocket household costs increased. Again, that was from $907 median in fiscal 22 to $960 median in fiscal 23. For the next few slides, we'll be talking about the households that are on the far right-hand side of this graph and talking about some reasons why members may incur high out-of-pocket costs. Next slide, please. Okay, so before we dive in, a few more definitions. As we discussed earlier, all GIC plans have a $5,000 individual or $10,000 family out-of-pocket max. However, if a member is enrolled in a plan with out-of-network benefits and they receive services from an out-of-network provider, the member may have to meet a separate deductible specific to out-of-network services and may incur coinsurance, which is typically set at 20% for out-of-network providers. So, for example, even if a member has already met their in-network deductible, they could incur significant out-of-pocket costs by having a costly procedure performed out-of-network, just as one example. Another way that we see members incur high out-of-pocket costs is through prescription drug penalties, which do not accrue towards the out-of-pocket max. So if a member fills a brand name drug when there is a generic equivalent available, the member is responsible for the cost difference between the brand name and generic drug, in addition to the generic copay. This is called the product selection penalty. The second type of penalty is a retail refill penalty, which is incurred when a member repeatedly fills a 1-month supply of a maintenance medication for a chronic condition at a retail pharmacy rather than receiving a 90-day supply through home delivery. After 2 30-day retail fills, during which time the member would receive a letter informing them of their options to avoid paying that penalty, the member is responsible for the full cost of the medication. It's often unclear as to whether the patient is actually paying these prescription drug penalties out of pocket or not because of the availability of manufacturer coupons, which are sometimes called copay assistance programs or discount programs. Manufacturers will offer these programs for new or high-cost brand name drugs, especially when there is competition from other manufacturers. These programs typically cover the entire penalty amount so that the member is actually only paying a small copay out of pocket at the pharmacy. But in these instances, we don't get any data from the pharmacy that shows that a coupon was used. This happens largely outside of the claims system. So this report includes all of the penalty amounts as out-of-pocket costs, assuming that the patients paid the full amount, even though that's likely not always the case. And finally, any member costs incurred for non-coverage services would not accrue to the out-of-pocket max and would not show up in our claims data. Next slide, please. So on this slide, we have some basic statistics for those households that had $5,000 or more in out-of-pocket costs. And that represents less than 2% of households, again, to the far right of that graph with the purple bars that we were looking at earlier. The number of households with greater than $5,000 and less than $10,000 in out-of-pocket costs increased from 3,642 households in fiscal 22 to 4,081 households in fiscal 23. The number of households with out-of-pocket costs equal to or over $10,000 increased from 164 households in fiscal 22 to 197 households in fiscal 23. On average, the GIC covers 90% of the total medical and pharmacy costs for these households with $5,000 or more in out-of-pocket costs. And finally, as we've discussed, utilization outside of plan parameters, which includes out-of-network utilization and pharmacy penalties, can cause members to incur these high out-of-pocket costs. Next slide, please. So every year in preparation for this report, we reach out to our carriers with a list of members who had the highest out-of-pocket costs during the prior plan year. We ask each of our carriers to describe the member's condition and the drivers of high out-of-pocket spending, as well as any outreach that the member received. This year, we included 71 members in the carrier surveys, and those 71 members had a combined total of $686,000 in out-of-pocket spending. The top set of bars shows the breakdown of members, and the bottom set of bars shows the breakdown of out-of-pocket spending. So of those 71 members, 46 members, representing 72% of the total out-of-pocket costs, had high out-of-network utilization as their top spending driver. Many of these members incurred high coinsurance costs for treatment at out-of-network providers. The most common primary condition among all of these members was cancer, followed by members with behavioral health, autism, and substance use disorder diagnoses. 6 members had orthopedic diagnoses, including a couple of members who received joint replacements at out-of-network facilities, and 5 members had cardiac conditions. This is a big part of the reason why we always encourage members to shop during open enrollment and verify that their providers and their preferred facilities are in network for their chosen plan. Next slide, please. So we also ask the medical carriers about any outreach that the members may have received. Of the 71 members from the previous slide, about 3/4 received some type of care management outreach, although ultimately only 28% were engaged in care management. There are many reasons why a member might not end up engaging despite outreach. Some members just may be satisfied with the level of management that their clinical care team is already providing, and some members just may not be able to be reached by phone. Next slide, please. So this slide shows similar breakdowns for our members with high prescription drug out-of-pocket costs. We surveyed our PBM on 32 members, representing a total of $811,000 in out-of-pocket costs. And all except for one of these 32 members surveyed incurred high costs due to prescription drug penalties. That one remaining member did fill their prescriptions at a VA pharmacy, and members with VA benefits can fill at any VA pharmacy with no cost sharing. So the VA pharmacies are considered retail, so the retail refill penalty would apply, but the VA pharmacy does not actually collect the penalty, so this member was not actually liable for the penalty amount. I'll pause there. I see we have a question.
It's not really a question. It's really more of a statement. I had received a number, more than I can remember, regarding the changes with some prescription maintenance medications that formerly were $75, that the member was paying $75 for a 3-month prescription, an improved maintenance med, that when we had Express Scripts and CVS Caremark, in 10 different instances, 10 different members had increased that same medication. It became out of pocket, and it was out of network, it was $165 for a 3-month supply of the same exact medication. And it was very concerning because that's a huge increase. percentage-wise as well as dollar-wise. And there were a number of my members who were very clear that they were not going to be able to afford that. And there is little information or direction from, certainly from CVS Caremark regarding discount programs and how those members might be eligible. And so that's very concerning to me because that's a huge increase in medications that they have been taking for the last few years with Express Scripts. And once we changed to CVS Caremark, the prices significantly increased, the cost to the members. So I want to raise that. I don't know if any of my labor colleagues received those complaints, but I received quite a few. So I was curious as to, and these are medications for which there is not yet a generic.
I would have to think that in most of these cases, and others may correct me if I'm wrong, that the retail refill penalty is likely at play here. And I will say, we did not change I know we've talked about this before, but we did not change the plan design on the pharmacy side, though we moved from Express Scripts to CVS. So I think it would, as always, be really helpful, Bobby, and I'm sure you have already done this, but share these cases with us so that we can investigate, really what the cause is there, and if there's options like discount programs, we can make the members aware.
Thank you.
Appreciate the feedback, Vice Chair. So just to bring us back to this slide, I do want to remind folks that the data for this year's report is only through fiscal 23. So this was before the change in PBM. So likely we'll be able to include some of that data in next year's report. So just returning to the data here, we had 18 members and 31% of the out-of-pocket costs that had retail refill penalties as the primary driver. That's listed here as RRA. And 13 members representing 56% of out-of-pocket costs had product selection penalties as the primary driver. In terms of clinical conditions, as we've seen in past years, seizure conditions accounted for the majority of these out-of-pocket costs that were largely driven by prescription drug penalties. Patient responses to different anticonvulsant drugs vary widely, and patients with complex seizure disorders may need to try several different drugs to find a regimen that is able to treat their specific symptoms. Several of the drugs with the highest product selection penalties in this category do have manufacturer coupons available, and while we have no way of knowing for sure, we believe it's likely that most, if not all, of these members used coupons given the really high penalty amounts. Next slide, please. All right, so just to wrap up, for our first objective, we explored trends in GIC member out-of-pocket costs. What we found was that the total 5-year increase in medical out-of-pocket costs for non-Medicare members between fiscal 19 and fiscal 23 was held below $3 per member per month. Growth in prescription drug out-of-pocket costs accelerated between fiscal 22 and 23, in part due to increasing uptake of GLP-1 agonist drugs. Next slide. And compared to the rest of the market, GIC members were relatively insulated from rising medical out-of-pocket costs between fiscal 19 and fiscal 23 due to GIC plans largely copay-based benefit design. Next slide. And finally, despite GIC members' relatively low average out-of-pocket costs compared to the market, a small number of members still face high out-of-pocket costs, largely due to utilization outside of plan parameters. And happy to take any questions here. That was my last slide, except for the data appendix.
I don't see a lot of questions. I don't see any questions. I do have.
Toby's getting that. I'm sorry, go ahead,
Here
Madam
we
Chair.
go. No, I see Toby now. Hi, Toby. Go ahead.
Yeah, I'm curious about your prior authorization process for GLP-1. Is everything both for diabetes diagnoses and also weight loss? Is that also, they're both subject to prior authorizations?
Correct.
100%?
Yes.
Okay, and what is the rejection rate? Or the approval rate? You can turn it around if you want to.
Sure. I don't have that statistic offhand. I think we could potentially look into that and get back to you with that information.
Yeah, I mean, do you have a sense? Not a percentage, but a sense.
Unfortunately, I don't offhand. I'm not sure if any of my colleagues might have more information, but unfortunately, I don't at this time.
Yeah, we can bring that back, Toby, and come back with some data on that.
Yeah, I'm just curious what the impact is one way or the other.
Yeah. Those are good questions. I wanted to piggyback off of his questions and potentially request that our June meeting, there's follow-up on this. I'm curious as to what the criteria are for the prior auth, and are there, step edits the patient, our member has to go through, and if we are approving, a high rate, what is the cost of these prior auths, and if the cost is great, yet we're at, 99 or 100% approval, do we benefit from having prior auths on these products? I don't know, but I'd love to see a little bit more dig in on that, since they represent such an enormous percent of our members' out-of-pocket growth. It's startling.
Matt, is this the only product that we have a prior authorization on? I don't remember.
Oh, no, we have
Okay,
a wide
then that's
range of
my
prior
lack of
auths,
knowledge.
particularly in the specialty drug category.
Okay, thank you. Thank you. That's good.
Yeah. I don't see
Madam Chair, just to acknowledge your feedback, we'll definitely take that back for the June meeting.
I would love that. Thank you. And I see, Bobby, you have your hand up.
Yes. Thanks, Valerie. I would also like to know how many of those rejected were submitted appeals, and of the appeals, what is the approval rate of the appeals? So I'd like to know that not only for the, weight loss and diabetes medications, but for all the specialty drugs. Because what I'm hearing is that people have to, go through hoops, literally, to receive an approval, and many, their doctors have to appeal, and that's very concerning. Either the, cancer drugs or the diabetes and weight loss medications.
Bobby, are you saying that you're asserting the fact that most of them are rejected and people have to come back, or you just want the data?
I don't know if, what the percentage of rejections, but I do know that there are rejections, and that people have to go through or their doctors are going through the appeal process. And so I'm curious, what that appeal process, how many, what the numbers are, and what is the outcome of those appeals.
Okay. Great.
Yeah, yeah, and I mean, I think that CVS Caremark, our PBM, should be able to give us, very detailed and specific data on, here are the products that we prior auth, here's our turnaround time, here's the percentage, what are the top 15 products that are prior auths, what are the edits, step edits, what are the hoops they have to jump through, how supportive are they in helping our members, what the ultimate approval rate is, how many get denied, and then what's the appeals, and then what's the time between, the first time a request is submitted to the time a patient gets the product, because, that's delay of care, and we'd like to see, from CVS's perspective, what that looks like.
Yeah. I see Commissioner McEnany has a comment, but before she speaks, I do want to say that care management, utilization management in the prescription drug space is highly valuable to us. And even in cases where you have high rates of approval for a particular drug, the mere fact of having a prior authorization can help manage the overall spend on a drug. So so we're happy to take these questions back and think about how to engage back with the commission in more detail. Clearly, there's some interest in how we manage specialty drugs. But I do want to say that, we have very few tools to manage rising prescription drug costs, and prior authorization for them to make sure that our members get the services when they need them, but that there is not excessive use that is not supported by evidence. That prior authorization is a really important tool there. But we're happy to take this back and think about how to engage further with the commission.
I would appreciate that. I don't have any problems with the prior authorization, other than I would like to know how long does that take, what that whole process is. But I do have an issue with people being denied medication, or denied on appeal when their doctor provides documentation. So that's concerning to me.
Yeah. Thanks, Bobby. Toby, is your hand a follow-up question?
Oh, I'm sorry. No, let me lower it.
All right. So hi, Eileen. I see you have your hand up. Go ahead, please.
Thanks. So I just wanted to reiterate a lot of what Matt just said. At a New England Employee Benefits Conference at Forum yesterday, a woman from CVS Caremark presented on these weight loss drugs, and she had made a couple of really important points. That care management and utilization management is critical to success of these drugs. And given their cost, you would want to make sure there's proper adherence, but also that they're supported by diet and exercise requirements, because that's truly what will make them successful over the long term. And so just as we think about how to formulate the prior authorization, just things to consider.
Yeah, and there's also a great deal of new evidence. I mean, this is a brand new category of drugs for weight loss. New drugs come on the market on a regular basis. Some of them more effective than others. So it's a quickly evolving marketplace, and we're working closely with CVS to make sure that we're on top of it. I do want to say too that, I as executive director can say that with confidence that we don't have widespread denial of care that is not supported by the evidence. The way that PBMs, and certainly ours through our contract, conduct these programs are highly regulated and overseen by this agency and by other state regulators. So I just want to make sure that people understand that while there we've created a managed care structure where utilization management is an important tool, right? And we need to be able to maintain that, particularly on the prescription drug side. We have performance guarantees with our vendor about kind of the turnaround time for prior authorization requests. Those again are heavily regulated as well, and we pay very close attention to that. So if there are delays, that they're on the hook for those, and we see them. So I just want to make sure that commissioners understand that we do, working with our vendor, keep a very close eye on this stuff to make sure that we find the right balance here, right? We need to make sure members get the care and the prescription drugs that they need. We need to be able to manage unnecessary utilization or utilization that's just not supported by the evidence. And we need to be able to manage cost. So it's a balancing act for sure. So more to come on this. We appreciate all the feedback and the questions, and we will come back to discuss this more with you all.
Thanks, Matt. I don't see any other questions, and we're confident, or at least I can say as chair, that the GIC is on top of these issues for expensive drugs, especially the GLP-1s. And the interest by commissioners is primarily data oriented. And, we do like to see data, and we're requesting, a deep dive into, prior auths. I don't think we've ever had one. And it sounds like CVS presented something yesterday that Eileen was part of. And so could we get them to drill in just for the GIC and request, a view of what they're doing? I think it may be an opportunity for us as commissioners to dialogue more. So we can keep moving. Let's move on to the next topic. Thank you, Lauren. This was excellent.
Thank you, commissioners.
We love the data. Look at this, very data oriented, doing some really good work for us. So thank you. So here's another exciting topic for today's meeting. A lot of substance here. Andrew and Erica, thank you for all that you're doing to reduce the waiting period. Let's hear more about the progress here.
Thank you, Madam Chair. Good morning, everyone. As the chair noted, we are moving right along with the reduction of the waiting period project. As you may recall, this actually, Leslie, you can move on to the next slide before I get started here. As you might recall, the fiscal year 2024 budget mandated the reduction of the waiting period for GIC benefits for all eligible new hires. What I want to highlight here is that the GIC had already been working on getting this reduced waiting period in place prior to that mandate coming through. And this mandate was really helpful for us in pushing that momentum forward and moving this project along. So the provision will be effective on July 1st of this year, which is coming up really quickly. And we've been working closely with A&F and A&F IT, as well as the Comptroller's Office, HRD, and others to make sure that implementation goes smoothly and development, communications, change enablement is all going smoothly before that July 1st implementation date. And again, some of this is just a refresh for you all since we haven't spoken about it in a little while. But essentially what this reduction of the waiting period will do is it will accomplish the goal of really eliminating many gaps in coverage for new hires to the Commonwealth. So you can move to the next slide, Leslie. So right now, again, this is a refresh slide. Massachusetts is currently located in the green slice here with the 60-day minimum waiting period. And once we implement the reduced waiting period, we'll move over to the blue slice with the majority of state employee plan offerings across the country. Next slide. So I really like to show this table as often as I possibly can because it highlights the impact that the reduced waiting period will have. So the top half of the chart where you see where it says current, this is what the waiting period was in terms of days for newly hired employees for the years 2020 through 2023. So you can see that we had members waiting up to about 90 days in some situations, which is a really long period of time. If we were to apply the reduced waiting period to those same numbers, you can see that the difference it would make is massive, and it would reduce that waiting period by nearly 80%. So again, the numbers on the bottom half of the chart aren't real numbers, so to speak. It's just if we applied the RWP to the years 2020 to 2023. So we anticipate about an 80% reduction of that waiting period, which is excellent, and we're thrilled about that. Next slide. Can you go back one, please? Thank you. So a few things that we've really been kind of pushing and quite frankly beating folks about the head with are these key items here. First and foremost, I want to highlight that anyone hired with an effective date before July 1st, 2024 will still be subject to the 60-day minimum waiting period without exception. This is something that we have been very clear on with all parties, all agencies who have been working with us on this upcoming change. There has to be a bright line where we switch over to this new rule, and that will be on July 1st, 2024. So again, we've been working closely with our counterparts and agency heads, coordinators at other agencies, municipalities, et cetera, to make sure that this is very well understood, that if you put in a hire date prior to July 1st, that employee will still be subject to the 60-day minimum waiting period. Anything after July 1st, of course, the new waiting period will apply. The other item that we've really been focused on is billing, specifically for agencies that utilize the HRCMS system. These agencies new hires will receive a bill from the GIC for the first month's premium. Billing is not new to the GIC. This is something that we do every month, every billing cycle. But this process of billing for the first month's premium is new for new hires. So what we've been doing is really working with GIC coordinators and others to make sure that they have the tools to educate their new hires about this process, about the billing, let them know that billing, paying their invoice in a timely fashion is required in order to avoid termination for non-payment, and really putting in place all the safeguards we can to protect folks from potential termination for non-payment. So a few things we've done are we've updated our billing, our actual invoices that with more color to really highlight that message. We've implemented a new email notification to members when a bill has been generated so that they can go into the portal and view it. We've also provided a few new reports for coordinators so that they can go into the Magic system and review who might have outstanding deductions not yet taken, things of that nature. So we're really excited about those improvements. We think that not just for the RWP, but across the board, it's going to be really helpful for our members. In addition, we've worked with carriers so that we increase our frequency of file or rather data transfer with them. So that way members can receive their enrollment information much faster than they have in the past. So they'll be getting a new welcome email, which is not something our carriers have done prior to this. And getting all the information that they need about their benefits much earlier than they had before. And lastly, although this is certainly not an exhaustive list of our key items, we're in the process, as you are well aware, given what we're working on today, of updating the regulations and issuing an administrative bulletin with further guidance regarding that regulatory update. I just wanted to also note that we are complete with our UAT penetration testing. There are accessibility testing, and I think one other is falling out of my memory at the moment, but we are completed with those. And two of those are still in the reporting and remediation phases, but the testing itself is complete. And testing with our third-party vendor applications is about 80% complete. So we're really making excellent progress. And I would say the bottom line here is that we are on time, on budget, and moving right along for our July 1st implementation date. Next slide. Oh, I'm sorry. I see Vice Chair has a question.
Yes, Erica, thank you for that. And kudos to you and the whole team for this, for getting this in order and, within budget and on time, within time. It's quite impressive. It's a huge endeavor. And thank you for that. I just had a couple of questions like regarding, the new hires, like how long do they have to select an insurance carrier? I understand that, they have 60 days in which to pay the invoice, but how long do they have to select a carrier when they're first hired?
Sure. So that amount of time isn't changing from our existing timeline, which is 21 days. They will still have the 21 days to be able to make those elections.
Okay, great. And then they'll be billed as soon as they sort of make that selection. Is that it?
Well, the
Pretty
bill
much.
won't populate immediately once they've made that selection, because obviously there are some calculations that need to happen. But once that bill is generated is when a member will receive that new email alerting them to the fact that there's a bill in the portal for them to view and that they can pay right then and there.
And it will be for the full months. I mean, their percentage, which I assume will be, for new hires, will be 25% of the premium.
Correct. And some
for
of them,
that carrier, right?
sorry. It depends on when the employee makes their election. So let's say that, they're on the ball, they know exactly what they want to do on their first day of hire, and they make those elections. It's possible that they could catch an earlier deduction, and so that bill may be less. But it really depends on the deduction schedule, when the employee makes their elections. That will really dictate what the amount of the bill will be. Part of what we've been doing in the change enablement and communications processes is really encouraging GIC coordinators to let folks know to make their elections as quickly as possible, so that they can try to catch a deduction. And we've also provided a new deduction schedule in our Magic system, so that coordinators will be able to view that and let employees know, okay, if you want to make this deduction, here's where you need to get your elections in by.
Okay, thank you very much.
Sure.
I don't see any other questions, so you can keep moving, Erica.
Great. So next slide, please. Great. So this is just a really high-level overview of where we've been, where we are, and where we're going for change enablement and communications. So in the last year plus, there's certainly more that's gone on than what is than these 3 bullet points here in the previous column. But we've made multiple presentations across GIC agencies, both, and when I say GIC agencies, I mean those who interface with the GIC. So Paul and I have been on a bit of a roadshow, a virtual roadshow, I guess, and presenting to groups like HRAC, which is a Human Resources Division group. We've presented to the HRCMS Core Users Group. We've also presented to state colleges and the chiefs of staff here in the executive branch. And really, as folks reach out to us and say, hey, do you have some time to come meet with us and just talk to us about this project? We make ourselves available and we meet with them virtually and answer their questions. There's also been email communications letting folks know about this change. And there was a primer in our usual annual enrollment deck for coordinators, just to really give them a heads up, really, that these are some of the changes that were coming. So right now, what we're working on is a dedicated training for coordinators regarding RWP. And those trainings are scheduled to happen next week, the 21st, 22nd, and 23rd, for online, offline, and municipal coordinators, respectively, for each of those training dates. These trainings are a really deep dive into our systems and the system updates that will be happening for each coordinator type. So the team has been really hard at work the last few weeks putting together these presentations and trainings, running through rehearsals and things like that to really fine tune these trainings and making sure that we're addressing any potential questions that we would anticipate coordinators may have. Each of these trainings is going to be a little bit different because each category of coordinator has a little bit different rules and interfacing with the GIC. And so we've been really careful to pull out those distinctions and make sure that everybody's getting the appropriate training for them. And we're also having our internal GIC staff training on these same changes tomorrow. We'll have 2 sessions tomorrow. So the team has been really hard at work there. For upcoming items, we're going to pull FAQs from these trainings that we're having next week, compile those and send them out. We'll also be recording the trainings, and we've worked with our vendor to create the word is escape, micro-learning videos. There it is. Micro-learning videos with step-by-step user guides, essentially, to walk folks through the process once they're in the portal. So there's a lot going on. We have some upcoming presentations with the Human Resources Division and the Comptroller's Office. And we're really excited. It's full steam ahead right now. And we're excited to get this underway. So I think I'll kick it to Andrew here for updates on our regulations, unless there are any questions.
I don't see any. It's good stuff. How many agencies in total do we have to find a way to communicate to?
Many, many, many. But it's actually been very successful. So just an example here, to get Magic access to our offline agencies, I'll have to go back to my talking points, my bullet points here. But just an example, we have, sorry, I'm scrolling through my notes. For offline agencies, there are 254 agencies that needed to fill out user agreements to authorize access to Magic, which they hadn't had before. And only 9 of those agencies were non-responsive with our multiple attempts to reach out to them and continued attempts. So it's despite as many agencies that we have, and again, that's just the offline portion, the outreach efforts have been really successful.
Yes.
If I'm not mistaken, and Paul can correct me, I think it's 918 different agencies that work with more than 100 different payroll systems. So that is the scale of complexity on which we're trying to implement. Well, we are successfully implementing a uniform solution.
Yes.
Thanks, Matt. I always get wary of misspeaking on that number.
It's a lot. Yes.
Yeah, it is a lot. And we're going so far as to cross-check our registrations for these trainings with our coordinator email lists to make sure that coordinators are registering for their appropriate training. And if not, sending out targeted emails and communications to make sure they understand the importance of participating in these trainings, or at least watching the recordings thereafter.
Nice. Well, good. Well, we thank you for that.
Glad to do it.
Let's keep moving. Yeah.
Morning, Commissioners. Thank you, Erica. In conjunction with the reduced waiting period, as Erica has just reviewed and discussed, we've had to make changes to our regulations that are found at 805 CMR 9, which is they deal with our eligibility requirements, enrollment requirements, and who can participate in the GIC. So as a reminder, we presented you with the draft regulatory amendments at the December 2023 meeting. And at that time, we provided to you the regulations that with the proposed changes redlined, along with a section-by-section description of the changes and the purpose of each change. And at that meeting, you voted to authorize us to move forward with the regulatory promulgation process. So since we met in December, we've had the proposed draft changes available on our website. We had a public commenting period and held a public meeting to solicit further comments on April 10th. At this point, we have received actually no comments. And accordingly, we have finalized the proposed changes as we had previously presented them to you. And the final draft without the red lines was in your packet for today's meeting. The next step is for you to approve us to move forward with the final promulgation process and to publish the amended regulations. And I'll ask for a motion to do so in a moment. Once you approve us to move forward, the final draft will be sent to the Regulations Division for their final review, and then they'll publish it in the Code of Mass Regulations at 805 CMR 9. And without further ado, let's go to the next slide, which has the motion. And I'll take any questions. And if we have none, we can move forward.
Yeah, I don't see any questions, Andrew. I just know we asked you potentially in December or a prior meeting, what's the total increase in costs that we'll be absorbing for this change? I think you gave us that answer before. And secondly, the requested budget amount for that 8.75, Jim, that you talked about, is that inclusive of these changes that we'll be making for new employees? Has that been modeled for the state?
That one I'll have to defer.
Yes, it's all in there. We've known this is coming for quite a while.
Okay. And total amount, Jim, that this is increasing, what we'll be paying across the state for the increase in coverage for new hires?
Right, so it's a little bit of different. We're a self-insured entity, as you know, so really all we pay are the claims for that next amount of time that the folks are insured. So we've estimated between $10 and $20 million, but it's very, very rough.
Okay. All right, thank you.
It depends on the pace of hiring and all those things.
Yeah. Okay, but we'll also still be paying the whatever amount of premium for that month 1, 2, and 3, or 1 and 2. So it's
well, the
it's
members do. The members will pay the employee's share. The state is self-insured, so we pay the claims, which in theory should match premium over the long run.
Okay. I don't see any questions. So if there's no further discussion on this, I will entertain a motion, as we see on the slide, to approve the draft regulatory amendments and instruct Andrew, our general counsel, to move forward with the regulatory amendment process. Do I have a motion?
So moved.
Second. Thank you, Bobby. Thank you, Liz. So I will now ask Andrew to take roll call across the commissioners. Aye, nay, or abstain. And Andrew, I'm an aye.
Thank you, Madam Chair. Vice Chair Kaplan,
Aye.
Designee Sullivan,
Aye.
Designee Butler,
Aye.
Commissioner Shabbat,
Yes.
Commissioner Choate,
Aye.
Commissioner Davis,
Aye.
Commissioner Edmonds,
Aye.
Commissioner Gentile.
Yes.
Thank you. Commissioner Guerin,
Aye.
Commissioner Jennings,
Yes.
Commissioner McEnany,
Aye.
Commissioner Murphy Rodriguez,
Aye.
Commissioner Silva,
Yes.
Commissioner Sinenko,
Aye.
and Commissioner Sullivan.
Aye.
And it passes unanimously, and we will move forward with the process. Thank you.
Yeah, thank
So
you.
before we move on, just a quick thanks to Andrew and Erica for the work here and for presenting today. As I think you can probably tell from the presentation, this is an enterprise-wide endeavor. It includes essentially every aspect of the GIC. So I don't think there's an element of our team that hasn't had some substantial piece of this project, from operations, IT, communications, legal, vendor management. So we're just really excited to finally be able to close this gap in coverage for our members that has been just out of step, I think, with not with others in other states necessarily, but with where we are in Massachusetts and our belief in the importance of health insurance coverage. So we're just really excited. So thank you for your support.
Yeah.
Can I just add two things? Just in line with all the work that's been done, we've also done administrative bulletins, which Erica referenced, that are directed to our different populations to help them know what they have to do. And we also, in order to make this work from the plan side, we in the amendments that will be going into effect for July 1st, we put in language to make sure the plans were doing their piece of this work. Just so we've tied it all up.
Oh, yeah, very good. I'm glad you added those comments, Andrew. And my hope is that Erica and Paul, as you were going on your roadshow agency to agency, you collected feedback and reinforced how committed the GIC is to members and constituents. And I hope that they're seeing that, either as agency heads or as, GIC participants. And your work is going to make a difference in how the GIC is viewed, and potentially then that could spill over to engagement and use of their benefits for better health outcomes, because that's what we're all here for, or at least I can speak for myself. So I'm glad that this initiative has moved forward at the pace it is, and it's really good work. So thank you.
Thank you.
Let's keep moving. I think we have one more substantive topic, or maybe not so substantive. Jim, you tell us.
Well, I hope they're all substantive.
Yes.
So this is our annual request for trust fund authorization. Next slide, please. As you may recall, historically and annually, the GIC has requested authorization to potentially use funds from the employee trust fund if needed. These uses of funds would only occur if the existing administration budget, so things that we fund our administrative functions with, was insufficient, or if there were new projects that came up during the course of the year that weren't planned for in that budget. Any potential projects must benefit the employees who have contributed to these funds, to this trust fund. And there is a process for approving projects. They're reviewed by senior staff and eventually and ultimately approved by the executive director, and then reported to the commission if we use the funds for any of these projects. The last 3 years, the GIC has not needed to use the trust funds for any projects. The administrative budget was sufficient to address all our needs, and we suspect that'll be the case in the year that's ending again in FY24. But nonetheless, this pre-authorization does give us the flexibility to address needs if they come up during the year. Next slide, please. I won't read through all the areas that we use the funds for, but a lot of them have to do with IT and information, IT technology and support, things around the magic system, making sure that our employees have all the tools that they need for both networking, storage, hardware, and all those kind of things, and that we can do any programming or additions to the portal functionality and those kind of things during the year if we need the funds to do that. Next slide, please.
I have
We
a
also,
question,
yes.
Jim. You know, I looked at this a few times, this particular slide, and the total seems incorrect to me. Total seems, you know, it seems that FY25 we're asking for an additional
20,000. Yeah.
additional amount. We're asking for $20,000 more in 25.
Let me see here. Did I make a mistake? It'll be the first one ever. So for the information technology, I can re-add the column, and I apologize if there's a mistake there. He's carried it over from last year.
It just looks like the $20,000. There should be a $20,000 difference for 25, an increase, because you're requesting for IT an additional 20,000, correct?
My quick math shows the far right column summary to be correct.
Right, can you tell me what row you're looking at, Bobby? Sorry,
I'm looking at the business continuity.
Business continuity, 80,000. Oh, I see, $80,000 to $100,000.
Right.
That is,
but the total is the same.
The total is the same. So that's the $100,000 should be $80,000. I apologize for that.
Oh, okay. I didn't know which.
It's the total that should be correct.
So essentially it's the same, right? You're requesting the same. That's why I couldn't understand the numbers, you know, didn't.
I apologize for not catching that.
That's all right.
Yeah, we're requesting level funding, so then everyone's clear. A level request from the year before. The areas are more illustrative than anything else. We just want to give you a sense of the areas that we might use it for and what those pockets of what those concentrations of funding might look like. We would come to the commission with a summary if we actually used anything for any of these projects. So these aren't particular projects. These are kind of a pro forma of what could be used if we needed to, in the areas they might be used in.
Okay, thank you.
Are there any other questions? I think I see a hand up.
Yes, hi, it's Rebecca.
Hello.
I was a Spanish lit major and my math is woeful, but I think the column on the left adds up to 388 for fiscal 24, and that the column on the right adds up to 408. So I'm not sure exactly what the correction should be. I just want us to be voting on the right amount.
Right. I apologize for that.
Right.
So to be clear, we are voting on 4088 is 408, correct?
Yes,
Jim?
that's right.
This is the correct amount.
So their request for 25 is the 408 on the FY25.
Just go back and make sure that last year's request, whatever it is accurate, and we put that in the slide so that it reflects what we voted on last year.
Will do.
Good call out, Rebecca. Thank you.
Thank you. Thank you, commissioners. Apologize for that.
So let's keep moving, Jim. Thank you, everyone, for attention to detail.
No, appreciate that.
Yeah.
So with that, I think we talked about the IT areas, and there's also areas in member engagement support where we might do certain communication projects or produce other materials as needed, such as videos that we've done in the past and those kinds of things. And that's what the communications areas would be about if we used any funds for those. Again, this would only be if the administrative budget were not sufficient or if we had new projects that we wanted to take on to benefit the members. And with that, math mistakes notwithstanding, I would move to answer any questions, or we can move to the motion.
Let's see. I don't see any other hands up. So let's move on to the motion, please. So at this point, I'll take a motion. Oh, we still have some more. more requests. So keep going, Jim. So sorry.
No, I'm sorry. This was the communication admin request that I just described. Oh, I should mention the temporary help authorization. My bad. We don't currently use any temporary employees at the GIC. We have, and it's been a few years now, I think, since we have, but we do annually ask that if needed, due to some event or some surge in work, that temporary employees were deemed to be a solution for, that we would have authorization to use up to 10 of those. Of course, we would report to the commission that we were doing that. But again, currently there are no plans to do that. This is a contingency planning request in case some event were to occur that we needed to supplement staff on short notice.
Okay.
And with that, again, I'm happy to answer any questions.
I don't see any. You're answering all our questions with your talking points.
Thank you. The next slide, please. Okay,
So here's the motion
there
that
it is.
we're looking for. Thank you, Jim, for the attention to detail. Here we have our motion to authorize Jim, our Chief Financial Officer, to pay for GIC expenses from applicable trust funds as recommended and requested only if needed. So at this point, I'll ask Andrew, since there are still no questions, to take roll call and for us to answer aye, nay, or abstain.
Someone needs to make the vote.
Oh, and make
the motion.
Yeah.
So
Moved,
I just want to be clear. So the motion is to pay certain expenses, right? Up to $388,000, correct?
For 408,000.
Right, up to the 408.
And then the-
408.
Yes.
Right.
So I thought, okay. So can we go back to that slide?
Give it a rest, Bobby. Give it a rest.
I just want to make sure the math.
We're not
is
spending
correct.
anything.
Well, we're authorizing it in case. So we're not spending anything right now, but we're authorizing possible expenditures.
So
from the
Bobby,
trust fund, right?
this column was added incorrectly. So see my
Yeah,
pen?
I know.
Right, so
FY,
it's
right.
the right-hand
So
column that
it's
we're voting.
$20,000 less,
This,
right? For fiscal 25, is that correct?
yes.
We're voting on fiscal year 2025 though, right?
I know that.
Yes.
Yeah.
Yes. Yes, but the total was incorrect.
No, the total is correct, Bobby. Here, 408. The mistake was in what we voted on for fiscal year 24, which is in the past now.
Yeah.
And then Jim detailed out on the following slide what the communication services would be. So that was the following slide. So in total, it's 408,000.
Right.
Should it be needed. And as Jim said, we've not needed to spend into the trust fund for any of these requests.
Right. Right.
Right. So Jim said, just correct me. Okay. Maybe I'm, having sort of, so last year, FY24, right? That it was 388,000. Is that right? Is that
Correct, yes.
$80,000, 388, right? Last year. And I thought you said that FY25, we're asking for the same dollar amount.
So I think the mistake is the other way, Bob. I get what your question is. It's the FY25 column is correct. The $20,000 should be added in. I think I've misled you.
So the 80, so
right,
the
it's the FY25 column is
80,000.
correct.
The
FY24 is the 20,000 goes the other way.
Okay.
So apologize for creating even more confusion.
Okay, I just wanted to
Desperately
be
trying
clear.
not to do it.
No. I just wanted to be clear what we're voting on, just in case we need to spend it. That's all.
Madam Chair,
Oh.
so moved.
Okay.
So it sounds like we
Mhm.
had a motion to approve by Jane, and do I have a second?
Second.
Okay, could we go to the motion slide, please? And I'm just going to erase my chicken scratch here if I can. So thank you, everyone, for that discussion and our attention to detail. And at this point, since I do have a motion, I will ask for a vote, and I will ask Andrew to take that vote. And we'll vote aye, nay, or abstain. And Andrew, I'm an aye.
Thank you, Madam Chair. Vice Chair Kaplan.
Aye.
Designee Sullivan.
Aye.
Designee Butler.
Aye.
Commissioner Shabbat.
Yes.
Commissioner Choate.
Yes.
Commissioner Davis.
Aye.
Commissioner Edmonds.
Aye.
Commissioner Gentile.
Yes.
Commissioner Guerin.
Yes.
Commissioner Jennings.
Yes.
Commissioner McEnany.
Aye.
Commissioner Murphy Rodriguez.
Aye.
Commissioner Silva.
Yes.
Commissioner Sinenko.
Aye.
And Commissioner Sullivan.
Yes.
Thank you. The motion passes unanimously.
If I could just say my apologies to the commission for that error. That's not on Jim. I'm the last one to review the slides before they go out, so that's on me as executive director. We'll make sure that doesn't happen again.
Thank you, Matt. All right, so thank you, everyone. Lively discussion, good vote, and always good substantive topics. So thanks, everyone. At this point, I will keep turning it over to Jim for the CFO report. So take us through the end here, Jim.
Okay, thank you very much. Appreciate it. Again, apologies for the confusion there on the trust fund slides. Here we have our spending on the state. Next slide, please. This is our budget update for FY24 to date. Here on this slide, as you've seen before, is our spending of each of our vendors for the period through April 2024. I'll get to the summary of this in a slide, in a subsequent slide with the charts, but you'll see that the spending in April has increased fairly substantially. Next slide, please. And this is also true for the employee share, enrollee share of expense spending, which is a proportion of the state share of the same expenses. Next slide, please. And here's the line graph that you're all familiar with at this point, but we're getting towards the end of the year. So you can see the blue is the shape of what we projected for the spending for this year, month to month, and the red is where we actually are. And in April, you can see that there's a delta between the blue and the red, which means spending was somewhat higher than we expected in the last month of this year to date. Next slide, please. This is the same slide, just giving you a projection of where we see spending going on the blue line for the next 2 months as well. So I won't spend a lot of time here, but for those who want to know what we're forecasting for the rest of the year, it is here. And next slide. Our cumulative budget is pretty much, the lines are right on top of each other. So we have a very small variance that I'll update you with some numbers on the next slide, but we are pretty much right at the budget spend through April. And next slide. Okay, so here are the numbers behind the charts, and as you see, we are $14 million under budget, which is a lot of money, but in terms of our $2 billion budget is only 0.6% of a variance. And then the notable part of this is we have been running about 1% or well, twice this through many of the months. So we did see an increase in April that we had not really planned for, that has changed the outlook to being pretty close to budget or maybe slightly under budget for the year. So we're monitoring this closely kind of at this point of the year on a week-to-week basis with the vendors. We have looked into it. As you know, paying claims is kind of the first wave of indicators that we get that something is happening. So we're digging into the data we'll be digging into the data warehouse later, and we're digging in with the vendors to see what's moving this forward. But some of the things are just a coincidence of some high cost claims. So high, that doesn't mean members, unlike with Lauren's presentation, that doesn't mean the members are paying the high cost of the claim themselves, just people with very acute or serious illnesses happening at a bit at the same time, and an increase in utilization and prices. It seems that the corresponding prices over the last month, more than we expected. So it's not very unusual. It's just this time of year. It's just notable as we head towards the end of the year, and it kind of changed our budget outlook. So that being said, I'm happy to answer any questions on this. And we'll report back next month, of course, to where we are as we get even closer to the end of the year.
Is there any thinking that will go, that the last 2 months will be significantly different than the projections from the first 10?
Well, April was, right? So we're concerned that May and June could also be. We're talking to the vendors now. It seems as though it'll be manageable. So we'll probably see this favorable budget balance perhaps go away, but we don't think we will end up in a deficit situation. But we are definitely seeing, as we know, prices are up. So if we get more utilization in combination with that, and a few more high cost claims than usual just happening to hit this time of year, these things can happen. So for the year, I think we'll be fine. We'll be on budget. It's just that as we move through the year, this is a change in our posture from where we have been.
Yeah. Okay. Well, it's all the good work that
it makes
and Paula doing, telling people about the GIC. People are getting more comfortable, maybe using their benefits as the good weather's coming. Who knows?
Right. There is some seasonality, which is why you see the shape of the curves there. It shows some seasonality that we know from year to year. Some months are always lower and some months are always higher, those kind of things.
Okay.
But we do want people getting their care, so we've budgeted for it. Makes it a little more exciting for the finance staff at the end of the year to make sure we land this at the amount we need to, but we're working on it.
All right. Well, thank you for that update. Any questions in the final minutes here for Jim? All right. Well, thank you.
Thank you.
All right. So at this point, we're right at the end. I don't know if there's any business people want to bring up. I certainly would like to request of the staff that we get some follow-up on the discussion that we had. We had really good discussion as a commission, and I'd like to request, a review of the PA approval process, in detail. So that is my request, and I don't see if anybody else has other business.
Madam Chair, just one piece of other business, just to turn to Jim on a procurement-related item before we wrap.
Sure. Is that
You're on mute, Jim?
I didn't know I put myself on mute. Just a quick update on where we are in procurements, as we like to do. We are ahead of schedule. Matt mentioned earlier on our dental consultant procurement, so we expect to come in June with a recommendation on a vendor there. So that's good news because it'll allow us to go out for actual dental services over the summer and be back in the fall with a dental recommendation. So wanted to give the commission an update on where we are on that timeline. We also, as mentioned before, will be putting out the notice to proceed on the data warehouse procurement, which is a major procurement for us, as folks who've been here through this cycle know, and that'll take several months to come to an end. But we are going to begin that process this month and work through the summer and the fall on that. And I believe that is all the procurement updates I have.
all right? Well, thank you. You will be very busy over the summer.
Yes, for sure.
Well, we appreciate it. Well, so at this point, it is right at time. I will take a voice vote to adjourn. So motion to adjourn. All in favor, say aye.
I think we need a, sorry,
Aye.
we need a
Aye.
vote. We need a vote, a motion and a second. Sorry.
Oh, we do. Well, that's okay. So do I have a motion?
I'll move to adjourn. Yes.
Second.
All right. And now all in favor? Can we just say aye, or do we need roll call?
Yes. Nope.
All right, everyone just say aye.
Aye.
See you in June. Thanks, everyone.
Thank you.
Thank you.
Wonderful rest of the week.